welcome to The Extra Mile. I'm Linda Boudreau. Our guest today is Sherri Daigle. Sherri is the Midwifery Program Coordinator at the South Louisiana Community College. Welcome, Sherri.
Hey, Linda, good to see you.
Wow, midwifery, I didn't even know that we were teaching it in our colleges.
Yes.
That's a huge, giant step.
It's huge.
You know, but before we get to that, let's just kind of step back. I assume that everybody knows what midwifery or midwives are, but let me not be assumptions here.
Okay.
What is a midwife? What do you do?
Midwife from the Old English means with woman. So, and the term obstetrician really means the same thing in Greek. But what midwives do is the portion of healthcare that pertains just to the birth and the year, the childbearing year. So you provide prenatal care, nutrition information, preparation for the birth itself, and then postpartum care.
Okay. And midwives have been around for a very long time, but they seem to have diminished in my memory. And I think it's coming back for us to have a whole curriculum.
It's back.
A whole curriculum. Tell me about the program.
Okay. South Louisiana has a midwifery program that is a 3-year program. A woman is considered a direct entry midwife, meaning she's not a nurse first. She gets the components from nursing that she needs to provide safe and effective care for low-risk women. And that becomes the issue, Linda, is these women are low risk. So you're not doing the burn unit, you're not doing the other elements of nursing that have nothing to do with childbirth. They have clinical training. It's about 3 to 1. They spend 3 years in school, about, in their time, I would say 3 times more in clinical practice. So they'll train with midwives, they'll train in birth centers, and they'll train in hospitals, observations, assists, and the actual catches. And when they leave, they have a license to practice midwifery, and they have a national certification from the North American Registry of Midwives.
Well, I am very excited about this, and I guess I have so many questions, I almost don't know where to start. But let me begin with, how did South Louisiana Community College have the courage to even bring this program in? Or is there a bigger demand than I realized?
There is a bigger demand. What we have is several champions at the state level who want to see changes, want to see innovation in healthcare. So we have directives from the federal government to train more healthcare providers. We know that we have 1 in 5 jobs will be a healthcare job. But we know that we need to provide lower cost alternatives without sacrificing quality. So when you hear the word innovation over and over, it's a way to put the healthcare in the street to the people who need it most without an increase. And you do have appropriate technology, but without an increase in those costs.
And so midwifery is one of those ways that we
Absolutely.
can do it.
Absolutely. It's not less care, it's a different type of care. So there are currently 2 programs in the country that are in community colleges. Most midwifery colleges are private, and some pretty big names out there with alternative health care programs. This one is a pilot project.
It's very exciting. And I
It's
think
very
it's
exciting.
very, very innovative. And I think it has the potential to have a big impact on the way that women have their babies. Because my personal opinion is, if women are offered a choice, there are quite a few out there who would choose a midwife over the more traditional hospital stay.
It's funny you should mention that, Linda, because what happens is women have been culturally and socially ingrained. It's ingrained into them that childbirth is fearful, painful, it's extraordinary, you must have medication to deal with it. And what happens is it's the fear, the fear, tension, pain cycle. The scarier you are, the harder it is. So the type of moms that we tend to deal with tend to be better educated. They're willing, they want a natural birth anyway. So it's a sort of a natural extension of their thoughts that, you know, if women have been having babies for thousands of years.
And they have, because we're all here from
we're
somewhere.
all here. Yeah, evolution is a careful monster. So I know that I can do this, and they feel like they want to do it with more of their options being preserved, more of their choices being preserved. What midwifery typically does is to provide safe health care within the context. You'll hear a lot of terms like cultural competence, culturally relevant, so that if you're providing more care than a woman wants, and especially if she does not need it, that's not really ethical. So if a woman wants to deliver either in the safety of her home, or she wants to deliver in a birth center, or wants to deliver in a hospital, it still has to be, their choices must be hers. So there are a lot of women who feel like that's going to take place more naturally. It's a natural progression if they choose a midwife.
So is it more risky to have your baby at home?
That's not what the evidence shows.
Really?
No,
Really?
but here's the catch. when people say that, what most women are going to say is, I would have died if I'd had my baby at home. If a woman is diabetic, for example, or she has heart conditions, she's not going to be a candidate for home delivery. But most women are normal and healthy. So you're talking about women that are between 20 and 40, typically, that eat well, that have enough education, that have resources to have good nutrition, they take good care of themselves, and they're psychologically prepared for what they're going to go through. They're low risk. A midwife can do that, and the statistics are excellent. Personally, my cesarean rate is about 8%, when the national average is closer to 40, and Louisiana's is very high. Let me say that, very high. But the problem is that we have high section rates, then you would think that the outcome is safe for babies. We're saving lives, and the evidence doesn't show that either. So
What does it show?
At least 1 in 3 births here are delivered by cesarean, yet we have the highest mortality rate in the country.
Louisiana has the highest infant mortality rate in the United States.
In the United States. Now, we vie with Mississippi every other year. We kind of fight for 49th and 50th, and I just think we can do
What a
better.
battle. What a battle.
Yeah, we won this year. Yeah, it's a shame, and I really think that we
It's
can.
more than a shame. I think, there's a certain, to me, sense of, you hate to use the word irresponsibility in it, but we shouldn't be losing our babies that way.
No.
And we shouldn't be losing our babies and our mamas that way, not in a country like this.
No, and if you lead a horse to water, okay, so if you give a woman the tools, you give her the respect that she needs and empower her, that's another buzzword of the new millennium. You empower her to make her own decisions and then help her to see where she's ultimately responsible, regardless of the outcome, she's going to make better choices.
Yeah.
Which leads me to another point. Lots of research has been done that when the mother makes her own choice, the outcome tends to be better.
And many pregnant women don't even think they have a choice. They think they can choose which doctor they want, and maybe they can choose which hospital they want, and that's the doctor they want only works at one hospital.
Yes, and if you don't know what choices you have, then you really don't have any.
You don't have any
So
choices.
we have, and this is not, I want everyone to understand that this is not us blaming physicians for all the terrible things in the world. This is a system that's gone awry.
Yeah. It's a systemic way,
Yes, it is.
and it's the way that we have been taught as women to have our babies.
Yes.
And what we're talking about today is an alternative, and one that the state of Louisiana and the higher ed system has seen fit to invest in.
Yes.
Which, again, for like the third or fourth time during
We're
this
doing
show.
something right.
Yeah, it speaks volumes as to the, to the potential ways that healthcare services can be delivered in a, I think, kinder and gentler modality at the very least.
Very good way to put it.
You know.
So our clients, I was going to add, our clients, the clients of midwives tend to do things like move around in labor. They do not ask for or want medication. I have a very small number of people who have chosen to go to the hospital so they can get pain relief. It virtually never happens.
But if they do, you can still go with them?
Oh, absolutely.
Okay.
Oh, absolutely.
So it's not either or?
It's not either or. Now, if we were to go to the hospital, which, like I've said, it's about 10% of the time, not quite even that, I'm with her, my role changes to, I'm no longer her care provider. She's choosing a higher level of care. Okay. But I step back into the role maybe of a doula, of a support person. They're at home, typically, we call it the aquadural, because you've heard of tub births before? They'll have water births, and what happens is they're so relieved and comfortable in the water, it doesn't occur to them to want more relief than that. So what women tell me is it takes the pain that they were experiencing from a 10, maybe an 11, down to about a 6. Okay. And that's doable.
That's way manageable.
So yes, the part that people think that they're just going to blow up, but the part that's really difficult is the last few minutes of labor. And so I find that women
and that
can
doesn't last long.
Not very long, no. No.
So part of what I hear you saying, and what I hope that people watching today will take from this, aside from the fact that we may have options, is that labor and delivery are manageable events.
Yes, they are.
And it's not something to be terrified of, because that's how you got here.
Yeah. Yeah, it works, and I've seen bumper stickers that say your pelvis is more than adequate. So we hear a lot of, the pelvis was too small. The baby just did not fit. The pelvis was too small. The pelvis is too small because the woman's medicating and sitting on her back or lying on her back in a bed. That's not how any other primate has a baby. That's not how any other mammal has a baby. If you saw a cat or a dog sitting on their rear trying to push a baby out, well, that compresses the pelvis, and then the pelvis wasn't big enough. So often I'm not criticizing because sometimes these interventions really are necessary, but we're giving epidurals to 95+% of our women. Then they can't perform, then we have to have a cascade of interventions to get the baby to go ahead and come out. So I don't know if you know that Louisiana has initiated a program called, I believe, the Birth Outcomes Initiative, that is asking physicians voluntarily to lower the induction rate so that we're not getting babies at 38 and 39 weeks anymore that were really not ready to come. Then after they're induced, the baby won't come, but we've already started the process. Then we have to do a cesarean because the labor is ineffective.
So one thing aggravates another thing.
Absolutely. And remember that there's not only the monetary effect, there's the medical effect, there's also a psychological effect of what happens to this woman and her baby when it doesn't matter what anybody says about this. It is a personal, emotional journey for a woman. And if she feels she's failed at this, even if it's not a conscious thing, that she's carrying that into her mothering experience.
Right.
And the state has several initiatives trying to help women to breastfeed. We know that breastfeeding makes healthier babies. There's no question about it. It's not just I prefer this and you prefer that. Your baby will be healthier if you breastfeed. Yet we're not using the policies that evidence shows us helps the woman breastfeed more successfully. So there are birth practices that help a woman breastfeed better and maintain her breastfeeding, maintain her milk supply, and have this wonderfully healthy, juicy baby. We don't do them.
Once again, we know what to do, we just don't do it.
We don't do it.
And you said a couple of times, and I want to get back to this, that women that use midwives, for the most part, are maybe more educated, more knowledgeable, they've done the research. And I'm sitting here thinking, that's nice, but what would it take to make this available to all women and attractive and appealing to a larger segment of women?
That's a good question. Midwives are by definition educators, and I would like to see every health class, we're concentrating on programs that teach people to be responsible with sex, right? Then they will not be necessarily responsible with procreation. It probably should be part of every high school class. I would personally like to do that, and we're opening some channels to be able to do that in the Lafayette area.
Good.
To teach young women what is available. And again, neither way, if it's forced on a woman, no woman should have to have a midwife if that's not what she wants.
No.
And no woman should have to go to a hospital with a physician if that's not what she wants and she's normal. But making people aware of the choices, because what happens is, the female in this young woman says, wow, I think that's what I want to do, especially before she actually has the fear that she picks up in pregnancy. Because, your mom has a story, and your grandma has a story, and Aunt Tilly has a story, and they're all the scary stories. They're not the wonderful, what women remember on their deathbed is their babies and what their babies meant to them and the triumphant experience of when they had their children. And I think we've lost that. Our culture has lost what it means to be a woman and a mother.
And it's such a big deal. Now, and there's a lot of research going on around midwifery now, and around a lot of research going on throughout the whole medical profession and how we're providing services. But you were saying before the show that there's a clinic in Florida that's run by...
Yes, there is. This is called the JJ Way. And this is Jenny Joseph. She's a phenomenal woman. She's a British African, or African British, excuse me if I'm not politically correct, but she is a foreign trained midwife along the lines of what we're going to be providing women. And she came here and started a clinic in Orlando, Florida, and believe I have the city right. And it was it could be Miami, but pretty much an inner city clinic. In Florida, midwives are able to take Medicaid. So the clinic took in women that were usually on the poverty level, usually either Black, Hispanic, Cuban, Haitian maybe, and other poor women in the community. And we all know that poor women don't do well. They're under-resourced, they're undereducated.
Bad outcomes.
Bad outcomes, all those low birth weight babies and premature babies and no breastfeeding because of the education. But she took them using the midwife's model of care, which means giving the woman culturally competent care. It's care that she has defined as relevant to her.
And that's what cultural competency means. She defines it.
Yes, that's exactly right. So then it doesn't matter if a woman is Hebrew, Arab, Catholic, or African American, or whatever she is, the way she defines it, it's been her choices that started to define that care. Educating them in how to keep a baby in, how to self-care, normal hygiene, good nutrition, because without good nutrition, Hippocrates knew this 4,000 years ago. If the nutrition from the mother to the fetus is faulty, this is a cause of prematurity. Yet we still eat the diet that, it's called SAD, what is it? Standard American diet?
Yeah.
And then we produce children that don't do well. So they teach them about the birth, whether they delivered with Jenny in the clinic or not. Some of them went on to the hospital because they were more comfortable there. But she reduced the rates of prematurity and low birth weight and lack of breastfeeding to the same as white women in suburban communities. That's phenomenal.
And see, that's my point. It's access.
Yes.
And some of that is driven by money, because you said, or by insurance, because you said in Florida, midwives can accept Medicaid.
Yes.
Is that something, I know that this is not happening now, but is that something that down the road Louisiana might be considering as we do all of our health care reform? Because that increases access.
Yes, we're working on it at a state level. We're also working on it, the midwives nationally are working on it on a federal level to increase the number of payer systems. Have you ever heard of the Blueprint for Action? It's the Transforming the Maternity Care System.
No, I haven't.
It's interesting because the state of Louisiana has embraced this initiative, yet some of the things that it calls for is payer system reforms, which means insurances and Medicaid have to open up and allow a few other professionals, usually meaning midwives, into this pool of payees. And then the other thing is increasing access to licensure for those people who want to be trained as midwives. So it's really unique, and anybody that's interested in policy should probably look at that. And it's available through Common Sense Childbirth, Transforming Maternity Care. And so our state is using it, yet I don't think they quite understand how we can implement this in innovative and safe ways yet. We're working on it.
It's a big job, anytime you overhaul something as huge as our healthcare system, anybody will tell you it's massive. But I do see inroads. I see at least we're chinking away at the old system. We might not have good, a lot in place yet, but we're getting rid of what didn't work.
If you had asked me 10 years ago if we could do this sort of project, I would have said it's not possible in a state like Louisiana, and we're doing it.
If you'd asked me 3 years ago, I
that's
would have
right.
said, because I've had midwives on my show before, and they struggle to get licensed.
Yes.
They struggle to operate without a doctor.
Yep.
And so it sounds like we're making
It's a
some
work in progress.
inroads
Absolutely.
now. So if somebody wants to use a midwife, or I guess have a consult with one, what is the procedure? I mean, are you all listed in the yellow pages? How do we even find you?
Actually, I never did. All of my practice was word of mouth, but there are several places you could look. If you looked on the Louisiana State Board of Medical Examiners, the same people who license physicians, there's a list of licensees there. You can look if you look up natural birth in Louisiana or midwives in Louisiana, there are several names that come up. And what's interesting about midwives is, I am not the midwife for everybody. So anytime a woman calls me, I'll give her several other people's names so that she can interview them. And I won't speak for everyone, but I know that all the midwives that I've worked with, I give a free consultation. So I'm giving 2 hours of information to each woman. Now, I'm not a busy doctor with a $100,000 malpractice policy, okay?
Right.
So I know that. Yeah. But I am a community educator and a mentor. My role is different. I'm able to spend the time with her and look at what she wants to do with her birth and where she is nutritionally and what is her payer system and what does she view, and then I see if I can help her or not. Sometimes it's not a match, and I'll tell her she's probably going to be happier maybe with this physician or with this practice. So it is not a business to me. It is a livelihood, but it's not approached as a business relationship for me. So sometimes I might go with that woman to a hospital. She's more comfortable there, or refer her to a doula that would go to the hospital. And sometimes just putting her on the road to the information is, that's my role. And if she ends up with me, that's great. And if she ends up with another midwife, what the mantra across the nation with midwives is a midwife for every mother. And we had talked about this earlier. Internationally, we have a shortage of 350,000 midwives. And I just came back from a symposium in Washington where they said, if the number of midwives we have in the United States here were to be shipped to Britain tomorrow, it wouldn't even fulfill Britain's shortage, and they're a country, I think, less than a fifth the size that we are. And in England, they're only doing about 3% of their births out of the hospital.
Wow.
Okay? So that tells you what a shortage we have here. And so our vision, I joked and said, I'd like to see, in 10 years, I'd like to see 50 midwives. And my boss said, I want to see one in every parish. So that's 64, not 50.
In 10 years?
That's what I'd like to see, yes.
Does that sound like a low goal, or does that sound like a high goal, or how does that sound to you? Because it doesn't sound that high to me. How many students in the curriculum now?
We have 9 students right now. They will finish in 2.5 years because they've already met some of their. See, our degree is a general, it's an associate's in science and midwifery. So they do have the general ed components. That's the first, not quite a year, but the first portion of their training. So then they spend 2.5 years with me in the midwifery program. So if we said that in the spring of 2014 we have, let's say, an attrition rate of 50%, if we had 5, then our mass of midwives over the following 2 years would be 13 rather than what we have currently, but within 5 years they're each training another one.
Yeah.
So yes, it is entirely possible.
I think what has to happen is, it has to, the training has to be available, and they have to, I think that for many of the students, they're going to have to feel like they have the opportunity to make some money and have a career once they get out. And so as this whole thing rolls out, I mean, it's all connected, but I can see it really, I can see it being a significant alternative for many, many women.
Absolutely. And, if we can't in 3 years define the problem, and, we have no more dollars to spend on health care this way, if the midwives are not there to fill that gap, we're really going to be in a crisis.
So how much money do you think midwives are saving us?
Oh, actually, that's been done. The state of Washington, which probably has a concentration greater than any other state of midwives, Jeffrey Thompson, who's their health director, who's their chief medical officer, if you will, did the research that said if only the 2% of women who are on Medicaid who would choose a midwife, they would save $8 million a year.
Wow.
Yes. So the cost
Wow.
savings, and we're not talking about women who needed sections, who are giving preterm birth. We're talking about a good screening mechanism for who and who is not low risk, then a care system for the women that do meet the criteria for low risk.
Because really, women used to, give birth in the cotton fields and, get back
And
up
go
and
right
finish.
back to work.
Yeah, I mean, so
Right.
for most women, it's an event, but it's not a medical event.
It is not usually a medical event. And then what we were concentrating on and talking about is the fact that if she's afraid, she has more problems. I love our doctors, but they don't do anything to alleviate that fear. The system, not the physician himself or herself, the system propagates that fear.
Because the system has hospitals and people in white jackets and people with,
I'll give you an example, and we work closely with the medical board here in Louisiana, and to me it's slightly problematic that sick people don't need to go to a doctor. So I'm spending the time and energy to tell these women you're not unhealthy, you're healthy, birth is physiological, not medical. Yet in this state, policy still mandates that we see a doctor before we can see the midwife. So it's like this upside down philosophy. It
Wait,
should
so if
be.
somebody wants a midwife, they have to go to the doctor first? You mean you can't accept them as a client? Do you call them clients or patients or moms?
I kind of go back and forth depending on when in Rome.
Yeah.
They're actually my clients or
Yeah.
my ladies, I might even say. Maybe that's a little condescending. Doctors call them patients, so
Right,
we tend to refer
right.
to them that way systemically within the system.
So you can't treat them if the doctor doesn't?
Not currently, not
Okay,
currently. And I
okay.
understand the thinking. I just believe that it's based on a lack of evidence. It's what we've always done. Have you know how we use the word also? We're talking about buzzwords in our culture. The word paradigm, the system we've lived under, the cultural assumptions that we've made that pertain to birth care. This is a short little story that I'd love to tell. Young bride is baking a ham, and she cut the bone end off and threw it away and put the rest in her pan. And the little husband said, well, why are you cutting the end off the ham? And she says, well, you have to cut the end off the ham. He says, why? And it goes on, well, my mother did. Well, let's call your mother and find out why. And they called Mom, and Mom says, well, you have to cut the end off the ham. And why? Well, you just have to cut the end off the ham. Well, why? Well, I don't know, your grandmother always did. So they call grandmother, who says, well, the pan I had was too small for the ham to fit in it. And that's the phenomenon that we've looked at.
That's it.
That we are seeing. We have always done it this way. It doesn't matter whether it works or not.
Or whether it makes sense
It
or
does
not.
not fit.
Okay.
It is not a one-size-fits-all model, and it does not work anymore. The balloon has gotten too big for the healthcare, the monetary issues involved. We have to change something.
And for the overall well-being of our moms and babies, because
That's right.
really, like we said earlier, you know, our infant mortality rate, our maternal mortality rate is way too high. Really quickly, in like 30 seconds, how can people get in touch with you, Sherri, if they want to go to school or have a midwife?
Yes,
or
find out
whatever?
more about midwives,
Yeah.
get a doula. Our students are working a little bit here and there. You would go to southlouisiana.edu. It's www.southlouisiana.edu. And if you call the school, what is our number? 521-8896 here in Lafayette. I can be reached. My name is Sherri Daigle, and I love to give the information out. The website has a lot of information on the program and what the general ed requirements are.
We got it. Thank you so much.
Sure, thank you.
And thank you for watching The Extra Mile.